Respected chairperson and my learned co-panelists on the dais, my dear friends and colleagues, I profusely thank both the presidents of ISCCM, outgoing and incoming, for having chosen this topic for discussion in current ISCCM conference. I congratulate ISCCM for having its first woman president in last 25 years. In next few minutes, we would like to ponder over the topic whether there is gender bias in critical care, either globally or in India. And if it is there, how to find the cracks in the glass ceiling to avoid it and to give a better unbiased environment. I dedicate this talk to my beloved husband, Mr. Sathe, who stood rock solid behind me for my career in critical care for more than 30 years. An artist with great creative mind and passion and compassion. I dedicate this talk to my family for helping me to crack the glass ceiling at various levels. I am an intensivist by choice. I am an intensivist for last 30 years, a woman with fulfilling family life too, and ready to do it all over again. The learned colleagues would say that anecdotes are not scientific evidence. Please show us the data. Unfortunately, there is not enough data. But maybe many anecdotes could make a data. We have discussed amongst ourselves on several occasions informally. Probably we will have to create data. Because lives saved is a statistic, but person hurt is an anecdote. And statistics become visible. Anecdotes are silent. But remember, they are salient. I am thankful for having invited us to write an article about gender balance in ICU in the current update of critical care medicine. Before we start looking at critical care medicine, we need to have proper perspective of what is happening at the national level. This was a survey of higher education in India. In comparison with the sex ratio at birth in India, which is 929 females to 1,000 males, we have to check how is the proportion of males and females in higher education. It is evident that almost 56% are male students. In arts and science streams, 53% are women, outnumbering the men. But in technical courses, engineering and management, only 28% are female students. With this background, let's see what is happening at the medical science stream. There are higher number of female students. 55% female students are proven to be taking education in medical stream. At PG level in medical science, approximately 2 lakh students have 44.5% males, again women outnumbering. But it is so unfortunate that an article in Lancet has shown that only 17% of allopathic doctors in clinical practice in India are women, which is extremely small percentage again in rural areas. Of course, this was a study about 10 years ago, and we need to create data again. What is the gender bias in education and employment in India? With the view of female feticide, thankfully, which is on downward trend, unequal exposure to basic education and unequal burden on a girl child when the family faces financial or social distress is very well publicized in Indian context. Also, traditionally and culturally, the upbringing differs for men and women. It reinforces the attributes of inequality in both men and women, and that affects clearly the way women choose educational streams and employment. Women are faced with workplace discrimination, unequal opportunities, lack of promotions, and pay gaps. It sounds very stark, but it has been proven in various studies. They are considered to be lacking leadership qualities. Why does this happen? Because it is perceived or thought of that they do not have leadership qualities and attributes such as competitiveness, assertiveness, and ability to drive change. Is that really true? What is happening in critical care? Let us check the global context. In global literature, repetitive themes in publications show that the critical care medicine has been considered a domain for males, largely due to long and irregular hours and stressful work. But Cabot et al. In their study showed that women fall prey to an irrational prejudice in clinical practice, where people prefer even a mediocre male doctor to an excellent female physician. It is not at all unusual for a female doctor to be called as a nurse or sister by the family of a patient or the patients. I have faced this in early phase of my career, that people would ask for a senior doctor to come and see senior male doctor. Understood. Why are women found to have inadequate progress in academic medicine? These are the findings from a national faculty study in the USA. Carr et al. Conducted a semi-structured telephonic interview across 24 medical schools in America in 2015. The gender climate in the USA had wide variations. Lack of parity in rank and leadership, lack of equity in pay, lack of retention of women in medicine, and a fairly large burden of family responsibilities and work-life balance on career progression. All of these affected inadequate progress for women in academic medicine. We were having an alumni meet with my students, quite a large number of them leading various ICUs at various places. I asked the question, how many are women in your unit? And many of them started looking at each other. I was shocked. I said, you have worked in our unit in your training days. And what happens? Why do you create such biased environment? And clearly they said, madam, we really want to appreciate the kind of support you received from sir during the career, but it doesn't happen at every level. Let us take some example. If a family member is sick, the woman in the family takes the responsibility of looking after the sick person, definitely by a natural instinct, but also often because of the family expectation. Of course, there are exceptions, I understand. There is a report from UK in 2012 that studied the pay gap among the healthcare professionals and found a difference of whopping 25% between male and female physician payouts. The report mentioned the caring roles females have to play, the hostile culture, and inability to change the jobs as a major cause for lower pay. Obviously, change in location, change in job is not at all easy for a woman to make. There was better pay equity in paramedics and nursing staff, just to show that women doctors really face a brunt of inequality. What happens in academic medicine further? Female first authorship had seen progress during the decades of 1995 to 2014. But later on, it has plateaued. That is the observation mentioned in NEJM. This is despite the fact that 50% of medical graduates and 30% of critical care trainees are women. This dark reality comes from resource-rich countries like Canada, USA, Australia, and United Kingdom and France, not to talk about India. If we consider the number of women participants in critical care consensus statements or clinical practice guidelines, the number stands at an abysmal 13%. Let us take an example. It is hard to believe that there are no women in critical care with the expertise needed to be on the panel. But the task force convened by ISCCM and ISCCM, which crafted the third international consensus definitions for sepsis and septic shock, had no women panelists, no physicians from low or middle income countries. Let us take Indian context, what is happening at ISCCM level. Out of total 187 founder members, 50 were females. Current total membership is approaching 16,000, of which 73% are males. Since its inception as a society, female membership has slowly but progressively increased. That's good. Current executive committee members are 28, of which there are only 4 females. In its more than 25 years of existence, till date, ISCCM has 1 female president. From 1994 till date, we have had 7 female vice presidents. You can see in this graph, which is self-explanatory, the female membership is in orange. At least it has increased from 2 to 3 digit numbers, as evident in the graph. In the last 10 years, the IGCCM has published various position statements. We accessed 11 such position papers published in last 10 years. Average female authorship among referenced position papers is 6.4%. IGCCM has 50% women on their editorial board. We have no accessible data on women in leadership positions like directors or lead clinical specialists, as well as there is hardly any data about dropouts who completely left the options of critical care medicine despite being interested in it. There are articles also which talk about female qualities which matter in healthcare. Over 1.5 million hospitalized patients were studied who were more than 65 years of age and looked at their 30-day mortality. Keeping all other factors constant, the patients of female physicians had a small but significantly less mortality at 30 days. Also, less readmission rates. It is also mentioned in their study that female physicians practice medicine little differently, probably give more time to their patient, more involved in psychosomatic well-being, and are more likely to focus on preventive care. Patients reported a better physician experience when treated by women physicians. What are the observations through the interviews of the dropouts? There was a study from University of Toronto which mentioned that aspiring women candidates are more likely to leave competitive medicine for non-profit organizations and search for part-time jobs very early in their career. This is where they stand to lose out on career progression and great growth opportunities, which is clearly observed in Indian scenario as well. They are also less likely to talk about discrimination at the workplace, work harassment, and more likely to face burnout or depression. I have had junior colleagues walking into ICU for morning shift with a baggage about whatever happened at home, with some different intentions to quit the family for the passion in the ICU. We do not want it happening either which way. We want to create a work-life balance for aspiring women candidates in critical care. So it is an extremely, extremely important role to groom these ladies. They should not quit clinical practice altogether due to inability to voice the multi-pronged problems. We are aware of Dr. Anandibai Joshi. In 1865, she was the first graduate of modern medicine who faced tremendous problems. Despite that, stood up. There are stories of tremendous grit and perseverance of women physicians. Many women are shining examples of handling the pressures of competitive clinical practice, familial duties, and caring responsibilities with vigor and courage. So let us talk more on positive note, how to find the cracks in the glass ceiling at individual level, organizational level, family level, and societal level. At individual level, the grooming becomes extremely important to avoid the dropouts. The mentorship and support for developing work-life balance and building resilience in women workforce in CCM is extremely important. And not only women mentors, the men mentors also have to play an equally important role. Job share is one of the experiments which I have been doing for last few years. Job share opportunities should be made available across institutions for anyone who cannot dedicate full time to their career but do not want to leave the career, do not want to have a break in the career due to other pressing responsibilities. As the time passes, gradually they will come back into the mainstream. We have to tell them personal problems are not a shame, but a reality. Doctors should be encouraged to speak out about their personal problems and find reasonable solutions. At organizational level, a lot can be done. First and foremost is the sensitization towards gender equity across the cadres, starting from top to bottom. Senior faculty members, either males or females, need to help and guide female doctors to overcome the career obstacles. Consciously, management and administration should nominate women for opportunities to be speakers, to be panelists, and project leaders. Women should constitute an equal percent of speakers, panelists, and experts in conferences as well and guideline papers. At organizational level, one of the major obstacles is in the maternity benefits and the age during which juniors go through family way. When a woman is going through family way, she becomes more grounded, whereas the male doctor becomes more free to take more responsibilities. We have come across stories of refusing to employ women going family way or with young children. These are numerous examples. It is shameful to say that it happens in the most learned section of the society. Maternity benefits should be made compulsory across the country as per international human rights, whether it is in organized or unorganized health sector. The conscious attempts to increase women at senior positions in the organization or the society to help create the required role models and mentors will make a huge difference. Institutional audits should be taken up to monitor pay parity rather than leaving it to individual demands. I remember in my early days, a senior management asking me, "Why do you need so much money? What does your husband do?" I cannot forget it. At family level, factually, the women who fulfill their natural role to bear children and raise them have to make compromises at the career level at their prime time. This must stop. And this can be stopped only by participation of understanding life partners. Whether or not the spouse is a doctor, they can be far more supporting. I'm sure there are glaring examples of partners who do it, the families who support. They do take equal responsibility at home, and women's careers are equally important for them. So maintaining work-life balance and creating de-stressing opportunities at family level is an equal responsibility of both the partners. The first lady editor of JAMA famously said, "We waste half our genetic pool of intelligence, creativity, and critical insights and experience. Medicine simply cannot afford that loss, and we have to all work towards it." Coming towards the end, it is a stark reality that a woman has to be doubly good to be equal. She has to prove herself. But it is time that ISCCM consciously decides to put it in place by creating enough database and put proper regulations to reduce this bias. There should be detailed surveys, data collections, personal interviews and communications to create the database. We all should take concrete steps to prevent attrition of this pool of talented and passionate workforce. And finally, overcoming gender bias is for the collective good of the society, patients, and physicians themselves. It should not be overlooked anymore. I dedicate my talk again and thank you for your patient listening.